From the heartland of the United States and one of the leading children's medical centers in the world, welcome to the Children's Mercy Kansas City Pediatric Bioethics webinar series. We invite international leaders to discuss critical and controversial issues in bioethics. Now, from the Bioethics Conference Center on the Adele Hall campus, here's Dr. John Lantos.
And welcome back, everybody, to our last webinar of the year, taking place during the closing weekend of our Pediatric Bioethics Certificate Program. We have students here who have come from all around the world for this last webinar, and they'll be joining us and I'm sure asking lots of questions. If you're interested in our certificate program, go to our website. We're now taking applications for the 2019-2020 academic year. That's scary even to think about. As usual, we thank our sponsors for this webinar series, Children's Mercy Hospital and the Claire Giannini Trust, whose generous support allows us to bring these to you at no cost. Although if you'd like to donate a little money, you can do that on our website as well. For those of you who haven't attended before, the way this works, we have a speaker who I will introduce in a minute. She'll talk for about half an hour, and then we will take your questions and comments. If you're here in the audience, there's microphones on your table. If you're online, there's two ways you can ask questions. One is in the little chat box in the lower right-hand corner of your screen, or for those of you who like to tweet, you can tweet your questions to us at #CMBioethics, and we will read those out as well. It's a great pleasure to introduce Amy Caruso Brown, who graduated just last year, graduated from the certificate program in 2017 and is now back to, gave a grand rounds this morning and back to do a webinar. She's an assistant professor of bioethics and humanities and pediatrics at SUNY Upstate Medical University in Syracuse, New York. She got her MD from Emory University, a master's in anthropology from Oxford, not Oxford, Mississippi, that's Oxford, England. She completed the narrative bioethics course at Columbia University and our pediatric bioethics certificate program. She writes a lot about cancer, about death and dying, about personal experiences as a physician, and you really should do a PubMed search and pull up some of her papers. They're wonderful. Her book about clinical ethics in pediatrics is coming out next year. Published by
Springer.
So look for that as well. And she's going to talk today about a really interesting topic. What happens when kids turn 18? Do they still have a right to keep coming back to a children's hospital? Welcome, Amy.
Okay, thank you. So I'm starting with this question, but we'll expand it. Is being treated in a children's hospital a right or a privilege? I don't have any conflicts of interest. I use a couple of abbreviations that I just want to, in case these are unfamiliar. AYA is adolescents and young adults. It's very common in the pediatric hem-onc literature. There's no clear bounds on those, so I'll explain more about that in a minute. And SCD for sickle cell disease. So let me put these out there. So just start by thinking about, picture a young person who is soon to be an adult, and this person has a chronic medical problem, which can be manageable, but can also be life-threatening. And they're followed by a pediatric subspecialist and well known to a particular children's hospital. Can you imagine any circumstances, and I won't ask anybody to answer right now, but just think, are there circumstances in which you think this patient should be denied care in a pediatric hospital? Not gradually transitioned, but actually turned away or admitted to the adults instead of to pediatrics, not seen by their subspecialist anymore, because that's part of the question that I'll be trying to answer today. So first, the case study, the story that led to the question was an 18-year-old with sickle cell disease who was frequently admitted to a children's hospital near his home for management of his pain crises and other complications. And there had been recurrent complaints from the staff regarding his behavior. There was general rudeness, which sometimes is as simple as, "How are you? How should I know I've been asleep?" So just sometimes just rude, just not polite to staff, but use of profane language, sometimes within earshot of patients and families, and suspected intimate behavior with a romantic partner while inpatient. So he and his girlfriend were in the bathroom together, and that was a concerning situation, and followed warnings from some of his nursing providers that they did not want to see this kind of behavior while he was in the hospital. But he has a really good relationship with his primary subspecialist and his primary nurse. There are people who get along very well with this young man. So during one admission, two events occurred. First, he called a nurse a particularly sensitive expletive in the hallway. And when I've talked about this case before, there are questions of whether I should just say it, but I won't. Reportedly witnessed by a parent and by a young child he was standing in his doorway. They were also stepping out of their room into the hallway at the time. And then this behavior with his girlfriend, particularly the incident in the bathroom. And these were the last straws in some ways for some of his providers. So just for a little more context about this hospital, the hospital where the patient was admitted treats children from 0 to 19 years of age. That's the automatic range up to even children who have turned 19 are automatically admitted to pediatrics and not to the adult side. Transition for children with chronic issues happens at a range of ages, depending on when their providers feel it's necessary. But there's not an automatic age of transition, and there's not a rule that says a, say, 22-year-old could not be admitted to peds. That does happen, but if you are a brand new patient to this institution and you're 20 years old and you come to the ED, you will go to the adult ED and get admitted to adult floor. If you're 19, brand new to the hospital, you'll go to the peds ED and be admitted to the peds floor. So that's the extent of hospital policy. And we have admitted children quite a bit older or young adults into their mid-20s. The hospital doesn't have any policies regarding how patients behave with significant others while hospitalized. So this is not something anyone has ever thought to write down. And adult hematology patients, this is important to note, are admitted to general medicine rather than to a dedicated heme or hem-onc service. And then an adult hematologist would consult on their care. So at this point, two staff members complained to their supervisor, who requested that the patient be transferred off the floor to an adult floor. This is a children's hospital within a larger adult hospital. So this is not a transfer to another hospital, but to another floor. And the attending physician on call objected, but eventually conceded to the transfer under a lot of pressure from many of the other people involved in caring for the patient. And he was then transferred to the adult floor for the duration of his admission. So these are some of the things in following up on this case, some of the things staff members said about his care. A child shouldn't have to see that regarding both his behavior with his girlfriend and his vocabulary. How would you feel if it was your child who heard that word? He was having sex and there are children on this floor. Try to get that outrage really good for this. Nurses on the adult floor are used to this kind of behavior, and I will come back to this because I'm not endorsing that statement, but it's something I heard a lot. And this kind of thing is expected on the adult floors, and I'll come back to the validity of some of these later things. But those were what people were saying before and after the transfer to the adult floor. So at this point, after and when I first became involved and heard about this case, the patient had been discharged, and it was in some ways said and done. But I asked, was this a medically appropriate outcome? Was this within the standard of care? And the patient was 18. So I think you could say in some ways yes, in some ways no. Was it medically optimal? Was it in the patient's best interests? Was it fair or just, and to whom? Because there were both staff and providers experiencing significant distress around the care of the patient, but also the patient and his family's distress over his treatment. And was it compassionate? And again, you could also ask, to whom? And then I also asked, would this have happened to a patient who was white, who was wealthy, who had highly educated or medically literate parents who were with him in the hospital? Because he did have involved parents, but they were not physically with him in the hospital all the time, but who were there and actively advocating for him. And sometimes I think this is the ultimate question for fairness in the hospital. Would it ever happen to the child of a physician? So first, one way of looking at this case is through the lens of the quote unquote difficult patient. I'm not going to spend most time on this, but I want to acknowledge it because it comes up a lot. And what does difficult really mean? In some ways, it's simply a label that describes our experience of a patient as a clinician, of their behavior, their communication, or their character, and puts quite a bit of the burden on the patient for that behavior. But difficult is really most of the time. I think many of us know a 2 or 3 or 11-way street where both the patient and the provider are contributing to the encounter being difficult. There are some characteristics that make patients more likely to be labeled difficult: multiple physical symptoms, high healthcare utilization, which fit this patient. And there's factors that make clinicians more likely to label their patients as difficult. So in studies, the range of encounters labeled difficult has ranged from 15 to 60%. And some of that, much of that, is on clinicians rather than patients and how they experience encounters. So you can interpret the duty to treat as us having responsibilities to repair these damaged relationships when we're experiencing patients as difficult. And I particularly like this quote: "If there's grounds to reconceive the difficult patient as a reaction to the perception of ill treatment, then there's an obligation to address this perception of harm." And we should and need to address the perceptions of unfair or biased treatment, which were certainly a part of this case. But it becomes quite a bit more difficult when the damaged relationship is between multiple providers and physicians and the patient. So a lot of what's been written has put some of the burden on physicians as one with the most power. Therefore, we have more responsibility to fix the relationship and address the perceptions of harm. But in this case, there were a lot of different staff members and providers with varying levels of power who felt that the encounters with the patients were actually with this patient were actually making it hard for them to do their own jobs. But I think a sort of unspoken part of this whole case was the perceptions of racism in sickle cell care. So if we're going to talk about this patient as a difficult patient, we have to think about how the context of his race and how he experienced racism as part of his care. So 80% of patients with sickle cell disease report trying to avoid care because of negative attitudes, either towards their disease or towards their needs and experiences with the healthcare delivery system. There have been several studies showing different levels of disparities for patients with sickle cell disease. Adults with sickle cell encounter longer wait times in the ED compared with other adults with complaints of similar acuity. Many adults report feeling like they've been labeled as drug seeking, and indeed clinicians erroneously seem to think that opioid addiction is more likely in patients with sickle cell disease compared to other chronic pain syndromes. And caregivers of children with sickle cell report similar concerns. There aren't any comparisons of pediatric to adult settings, but children with sickle cell do experience greater delays in receiving pain medication compared to children with fractures. And that was a study done in part because it's really hard to find another racial comparator group for sickle cell pain. There aren't enough white patients with sickle cell or even non-Black patients with sickle cell to do comparative studies. So they took a group that experienced a lot of pain for a different reason and was predominantly white. In vignette studies, providers are less likely to provide opioid medication to Black children compared with white children. And there's increasing evidence that stressors can trigger crisis. There's a lot of evidence overall in healthcare that racism contributes to poor health outcomes, not just by access or changes in treatment, but by the physiologic experience of the stress of racism. Now there's new data looking at experiences of racial bias and the likelihood of a pain crisis. So all of these were contributing to this patient's experience and to his labeling of being difficult. But I also think there's another way to look at this case, and I want to spend most of the time on this because I think this is the most interesting part. What about the bigger picture in this question? And if you don't just think about sickle cell disease or don't just think about this patient, but about how we treat patients on the cusp of adulthood in general. And so I asked the questions, are children's hospitals places of privilege? And if so, who gets to claim or exert that privilege? Who should have access to them, and when can we deny that access, which is really what we were doing in this case? And is it ever ethical to refuse pediatric care to a patient on the basis of behavior? And does age matter in that case? So I'm going to say a little bit more about these and tell you what I think, and then I hope to hear what you all think as well. So children's hospitals are indisputably, to my mind, places of privilege. This is what you get when you Google children's hospitals: bright, beautiful, colorful. I think anyone who works in a children's hospital, particularly in the US, would probably attest to this. Resources are much easier to come by in pediatrics, and maybe particularly in pediatric hem-onc. And in studies of transition, adolescents consistently see this difference. They know that adult hospitals are less friendly, more threatening, more depersonalized, that you don't get the level of sort of coziness and comfortable. People are not handing out gifts in the hallway of the adult hospitals because you have to go through being in the hospital. So it's unsurprising then, I think, that teenagers on the verge of transition recognize this. They recognize that there is something to be lost in the transition. And I think they are places of privilege, and we should acknowledge that. Why do we treat children and teenagers in hospitals in the first place? I think that asking this is part of explaining why, if ever, we can transfer someone or force someone to go to adult care against their will. So the easy one is the biology and psychology piece. And this is a popular quote, at least in med school here. Not just little adults. So children, adolescents, and even young adults, there's no clear, bright line at which those different biological and psychosocial needs disappear, but they're certainly present into early adulthood. And that's one reason to have children's hospitals and specialized pediatric care. There's also the issue of vulnerability by virtue of both their legal status and their legal autonomy, but 18-year-olds have that. What they don't necessarily have is full development consistent with an adult. They still have evolving autonomy, and particularly teenagers with chronic diseases have often had a lot of involvement from their parents in their decision-making up till now. And ideally, they've had some preparation for making decisions on their own, but they're pretty used to having their parents involved in their care. And then there's innocence, which I don't think gets spoken aloud as often as it is thought to us. And I think it's an underlying theme in some of the voices of the staff, particularly around comments like adults are used to this or adult nurses expect this sort of behavior. So in the West, at least, the period of childhood is constructed as a time of innocence and insulation from responsibilities of adulthood. And it does beg the question of when that innocence ends. So vulnerability, I put a lot of weight on this as a reason for treatment in children's hospitals, and I think it justifies some of the reasons why we don't immediately transfer children the day they turn 18 and have legal autonomy, that they're still vulnerable in many ways, and adolescents with chronic diseases are particularly vulnerable. In general, for sickle cell disease and transitions, the mean age is about 19.6 years. And in a big survey of centers, just over half had a required age of transition, so most actually did not. But 3/4 transferred patients due to pregnancy, which I would argue is more about behavior and innocence, which we'll come back to, than really about a pregnant teenager being unable to be cared for by a pediatric provider. Although they also need OB care, there are not any real good reasons pediatric hematologists can't continue to care for pregnant patients with sickle cell. Only about 60% of centers reported being able to transfer patients to an adult hematologist with sickle cell as a specialty, and 10% had no adult hematologist at all. So this goes into one of the big barriers for transition, which is simply access to care for teenagers. Transition is associated with negative outcomes. Although it can be done well, it's often not. And so after transition, teenagers and young adults have lower adherence. They miss more appointments. They tend to have negative health outcomes. And in particular for sickle cell, mortality rates seem to accelerate in the first few years after transfer. And in this case, the provider, the primary hematologist, had particularly considered that and was trying to put off his transfer longer to do some things like a chronic transfusion protocol that she thought would help with his outcome and decrease his risk of mortality after transfer. The barriers can include letting go of relationships with pediatric providers, but the second one, the difficulty of finding and accessing qualified providers, is a big one. And a big issue is insurance access and Medicaid access. So it can be very difficult in many communities to find adult providers who accept Medicaid, where the vast majority of pediatric providers do. And then there's the difficulty for patients of acquiring adequate knowledge and skills to take a more independent role in healthcare. And this speaks to transition not generally being an abrupt event that happens suddenly on the floor because of bad behavior, but something we want to do gradually over time to make sure the patient is really ready for the transition. Socioeconomic status impacts transition. So in general, and this is for all diseases, not just sickle cell, adolescents from lower socioeconomic households and from racial and ethnic minority groups seem to be less likely to discuss transition or have transition plans in place. They have more difficulty accessing care and longer gaps between their last pediatric and their first adult visit, and they tend to transition at an older age, which is probably, again, due to that access issue rather than concern for their greater vulnerability because of their resources. On the provider's part, there's also a lot of barriers to transition, and many providers are not aware of guidelines. They don't have access to a supportive program to conduct the transfer. They may not be aware of evidence for interventions that help transition. And transition doesn't happen in a vacuum. If there's an inability to identify and tap family, social, and community resources to support patients, that's also going to make the transition difficult. So what does a successful transition look like? Sometimes it's measured simply as following up with an adult provider. Did they show up to their next visit? You can use measurable health outcomes, so things like hemoglobin for a sickle cell patient who's on hydroxyurea. adherence to treatment, independent self-management skills, and well-being. So psychosocial well-being is probably the one that doesn't get asked about enough, but is pretty important to the success of a transition. Skip over this part. So the other half of this coin, the less discussed half, is innocence. And I think it raises the question of, should the perceived loss of innocence, which goes with some of this patient's behavior, the profanity, the sexual behavior, equate to a loss of access to care? And I think this is problematic for a lot of reasons, but maybe particularly because innocence is so closely linked to race and our historical ideas of innocence. Robin Bernstein is an American history professor at Harvard who has done a lot of work on this recently and written a really interesting book. This is from an editorial in the New York Times last summer showing imagery going back to the 19th century of how childhood was portrayed for Black children versus white children. And there's a huge number of studies now showing how perceptions of age are filtered by race. It's very common in narratives surrounding violence towards young Black men, but there have also been some interesting studies in controlled settings. The one from UCLA looked at white undergraduates, and they consistently overestimated the age of Black boys by 4.5 years, and also found them more culpable than white or Latino boys when they were matched with serious crimes. And in the Georgetown study, they looked at adults, and they consistently described Black girls as needing less nurturing support and protection than white girls, and as knowing more about sex and other adult topics. And this is the theme that is hardest to pull out of this case because people don't want to talk about it. And when I talk to the providers about it, they consistently say, but his behavior was just so bad that the race is irrelevant. It's very hard to get people to recognize what role it might have played to have an angry young Black man yelling profanity in the hallway versus another angry patient. So given all of this, where does the right to care in children's hospitals end? Is it the age of legal majority, which I think not, or some earlier chronological time point? When I was in Oxford last summer, our gray zone is sort of 18 to 24. Their gray zone in oncology was 15 to 19, which is quite a bit younger. And it was hard as a pediatric oncologist to imagine sending a 15-year-old to the adult floor. So clearly there's not a hard, bright line, certainly not around the world. Is it some key point in their cognitive, social, or emotional development? Is it certain milestones? And we do this sometimes where we say, oh, but they're married, so they must be an adult, or but they're pregnant, which is probably even a more popular one, though arguably most teenagers and even young adults' pregnancies are unplanned and therefore not necessarily a marker of good decision-making or readiness for transition. And underlying that is this perception that that's adult behavior or not innocent behavior, when really it sort of reflects typical adolescent decision-making and not necessarily adult decision-making. And who gets to decide in all of this? Is it professional organizations? And our professional organizations do have policies. WHO says 19, AAP says 21, but also puts it in the hands of providers and families to work together and figure out the best age for transition. Many hospitals and health systems do have their own policies and their own criteria, or is it individual providers? And what evidence should they use for that? I would argue that it's when the key milestones are met that indicate this person can transition successfully. That it's when they're demonstrating that they've met these developmental points where they can actually take more ownership of their care, because once they transition, they're not going to get the level of psychosocial support that is typical of pediatric care. They're not going to get the repeated follow-up calls for the missed appointments and the quick rescheduling to make sure they get in. And that's a reality that we all have to face. And who should decide? It should be a shared process between patients, families, and providers supported by formal programs. It should not be the decision late on a Saturday night, as this was, that this patient is just too much for the staff to care for. Most of all, I want to argue that transition is not a punishment and should never be used as a punishment, and that pediatric care, conversely, is not a reward for good behavior and for cooperation, and that to treat them as those kinds of things is unethical and loses sight of the original reasons that children's hospitals developed, that pediatric care developed as a specialty, and that AYA, or adolescent and young adult care, is now a growing specialty in many fields. The opportunity to be a child, and I mean that as being perceived as innocent and automatically deserving of certain things is not a privilege that every child is granted. But I agree very much with this sentiment that children deserve equal protection, and the special protection of being treated in children's hospitals, not because they're innocent, but just because they're people and they're vulnerable by virtue of where they are in their developmental period in their life. And this applies maybe most aptly to young people on the verge of transition. Transfer to adult care is not and should never be a punishment. And the staff in this case claimed certain privileges, sort of by association, rights of being pediatric providers. But I would argue that healthcare providers have the same rights regardless of who they treat. And so I've talked about this case quite a bit with nurses and providers on the adult side who maybe agreeing that there may be somewhat more yelling, but maybe not necessarily, would say that no, being called certain words is not a part of their daily job, is not something they go into work expecting, and is not something that they tolerate there any more than on the pediatric side. These are suggestions, and I'm still building up the argument to these points, so I would be interested to hear them discussed. I think in general, clinicians can benefit from greater understanding of the sociological and historical contexts, and that is something I'm still working on with my own staff in my own hospital in terms of discussing this case. Race just matters, and I think we should take the question away from if it matters to how does it matter, why does it matter, and what can we do about it? Judgment of a patient's action has absolutely no role in the timing of transition, and it's not our role as providers to judge them either. It's our role to work with them and help them get the best health outcomes we can, including the best outcomes through transition. And we can do more, much more, to support adolescents in transition than we are doing. So I'm curious to hear what people think about that.
That is a very challenging talk. I was surprised that you didn't talk about bed in a children's hospital as a scarce resource. And that the longer we keep adolescents, older adolescents and young adults, the less available that scarce resource will be to children. And if adolescents and young adults can get good medical care in the adult setting, then obviously the specialty care they get in the children's hospital is taking something away from somebody.
That is a very good point, and I'm probably a little skewed. We do sometimes have bed shortages, but we also have a lot of bed shortages on the adult side in this particular hospital. So that probably skewed my point of view, but I think you're absolutely right about that. And the question is, are we transitioning young adults when they're ready consistently, regardless of, say, how much we like taking care of them? So the counter case to this case happening at the same time was a 19-year-old with sickle cell who was new to our program and actually probably should have not been admitted to pediatrics on the grounds that he didn't have established pediatric hematology care and was so close to when he would normally have aged out. It would have made more sense to start with an adult provider. But he got admitted and turned out to have a lot of complicated other medical problems that, while on a pediatric floor, required the care of 4 other adult subspecialists. And when I wanted to transfer the patient, the nurses said, no, but we love taking care of him so much. He's so wonderful. And he was a wonderful young man. He was very polite. He was very pleasant to care for. So I would argue that that is a great point, but only if we are applying it fairly across the board. That when this is a patient who medically would have benefited from adult care, would probably have been better served by adult care, and yet was staying in peds because he was a joy to take care of.
Right.
So that was the perfect time for a really good transition. But yes, the shortage is definitely something to consider.
So let me remind people online, if you want to make a comment or ask a question, just type it in that little chat box in the lower right-hand corner of your screen, or if you like to tweet, we're at #CMBioethics, send in a comment or question and we will read those out. Manisha, did you have a comment?
Yeah.
Do you have your microphone?
I would like to share our experience from India. 2 groups of patients who come to my mind as I was listening to your talk. One is children with thalassemia. We see a big group of those children coming to us. And the second group, which is increasing in number, is with juvenile diabetes, type 1 diabetes mellitus. And what I'm going to share is, I'm a neonatologist, so I'm not directly involved in their care, but my colleagues who are taking care of them, so their voice. The children with thalassemia who are they're used to coming to the pediatric ward and getting their blood transfusions regularly. And the nurses get so attached to them during this process that transitioning them to the adult care really becomes difficult. We have, I shouldn't say now children, adults, 25, 28 years, still coming, prefer to come, not being, on a pediatric bed, but still they would prefer to be there rather than go to the adult center. There's a 25-year-old who still comes. The same thing about children with type 1 diabetes. I remember my colleague who takes care of them saying, "Oh, I just sent him to the adult diabetologist and they've messed him up." And then he comes back to us and then she says, "I had to give him an appointment." So probably I agree with you. There is a need of communication between the pediatricians and the adult healthcare providers, wherein there has to be a transfer of the case and the background and whatever the family issues. But one of the important things, you talked about race, but what I thought in our own community, the socioeconomic status and the education of the parents is what matters the most. It's not the racism that I would talk about, because if the parents are educated and well placed socioeconomically, they take over the care of the child or the young adult, whoever, and they would decide when they want to go to the adult healthcare provider. So that makes a lot of difference in this transition, and it goes on smoothly. Just another point which I want to add is about you said, when do we admit the child to the pediatric department? I remember a case, a 17-year-old coming with encephalitis. And then since he was a 17-year-old, we take till 18, he came to our PICU and he was admitted and ventilated. But then he was never comfortable there because it was an acute admission. I mean, he was not a regular visitor to the Department of Pediatrics, and he came all of a sudden at 17 years of age, and even the nursing staff in the PICU were not very comfortable taking care of him, and they said, "Oh, why didn't he go to the adult side?"
Like your 19-year-old.
So there is a difference about if an acute emergency comes, where do we put them, in the pediatrics or in the adult? So that's something I would like to listen to your comment
So it's
on.
interesting, the socioeconomic status piece, because when I started thinking, when I started trying to write about this case and thinking about the case, I had been in England and was visiting their pediatric oncology program, and one of the physicians said to me, "Well, if you're a 17-year-old who's at home studying for A-levels, you'll probably end up with a pediatric oncologist, but if you're a 17-year-old plumber's apprentice, you'll probably end up treated by the adults." And I thought that was a really succinct sort of socioeconomic status and class summary. And I thought I would find similar things in the US, which the data is actually really tremendously hard to come by. Nobody seems to be reporting it, but it doesn't seem to be that poorer adolescents are transitioned more quickly to adults. It seems to be, and that may just have to do with our insurance system and Medicaid here and how difficult it is to find an adult provider who will take a chronically ill young person. But it didn't seem to be that just because they were maybe on their own or didn't have parents as involved that they got pushed out of pediatrics. Instead, they seemed to linger in pediatrics longer, which was the opposite of what I was expecting. But I think you're right. Involved parents sometimes they can hold back transition if they're not involved in sort of a productive way, but involved parents who are educated can really help a teenager make a successful transition to taking ownership and responsibility. And I see it both ways. On the pediatric oncology side of my practice, I have college students whose parents still make their phone calls, who call at night and say, "He's calling me from college and says he has a fever." And we say, "Well, he could just call us because you're not even there, and we're going to send them to the ED." So that's sort of a failure of transition. But the other way is the parent who says, "Now you're off at college. You need to know where the local emergency room is, who you're going to call when you have a problem. You need to start setting these things up." And that's a successful transition.
So again, if anybody has comments online, just type them in the chat box. Mara, did you have your hand?
Yeah.
You have a mic?
I do. Okay. So when you first started talking, it was sort of framed in the way that you were going to be discussing, when can pediatric patients be moved to the adult hospital. But then when you got more into the talk, it seemed to me you were actually discussing like a much more narrow issue, which is, does bad behavior justify moving somebody into an adult hospital? And your answer seems to be no. And just another way to frame that is, how do we deal with bad behavior? And your answer, well, it's not by moving them. So I'm curious, what would happen in a case? So an easy way to kind of, I don't know, turn the argument, people who want to move them into the hospital, show them that they're wrong, is to be like, well, imagine he was, 12 and behaving this way.
Mhm.
Like, obviously, we wouldn't move him there. So I'm curious if hospitals in general have policies for just misbehavior. And it just seems that if they happen to be older and misbehavior, like moving them is an excuse or easy thing to do.
Yeah, so there's a couple of pieces of that. One of the counter arguments has been, if we really felt like these relationships were so broken they couldn't be repaired, then perhaps building up new relationships with the adult team might have been an option. I don't think we felt like that in this case, and I think there's all these issues of his vulnerability and the increased mortality, particularly for sickle cell around transition, that made transition not the right thing to do. But in general, for difficult relationships and bad behavior, so some people have tried contracts, and there's some evidence to suggest they don't do very much. My experience and our experience at this institution was that we had a previous long running, it was over almost a year, of a patient who was in the hospital for a very long time, where the parents, and particularly the father, were very verbally abusive towards staff, and also wrote about them online, did a lot of really negative, kind of threatening things, and a contract was initiated. Hospital counsel was involved, social workers were involved, and when the contract, this was well into the problem, so not really at the point where it was likely to do anything, but when the contract was violated, visitation hours were cut back for this family and had to be supervised by security. So that's sort of the worst case scenario, but it also highlights we don't do the behavioral contracts until things are really bad, and by then it's really too late to fix the relationship. So I think what needed to happen was an earlier recognition and a more cooperative, less threatening, and less judgmental approach. So for this patient particularly, less of, you aren't allowed to do any of this with your girlfriend in the hospital, and if she's in her room, the door must be open, the curtains must be open, you must have no privacy whatsoever, which is very paternalistic and not from people who are really this patient's parents, and I don't know what behavior his parents permitted at home, if they did, but telling him basically, you are having all of these things that he was also saying helped him cope. So he was saying, having my girlfriend there when I'm in the hospital for these prolonged stays helps me cope with my admission. It helps me cope with pain. It helps me feel like a normal teenager. And we were saying, no, we think sex is bad, so we're going to take that away. I think those were some of the points where the relationship started to deteriorate, where I think if we had come in with less judgment and more willingness to work with him and see him as a partner in his own health, that we might have been able to prevent the ultimate deterioration of the relationship.
One of the things about contracts with the parents, you can banish them.
Yes.
It's hard to banish the patient.
Yeah, and in the adult services,
what's the consequence of breaking the contract?
For this kid, they use transition to the adult as the consequence, which I think is the problem.
Yeah.
Is and on subsequent admissions, that was you'll go, but that's, I think, sends a very wrong message about the purpose of adult care and the purpose of transition, that we don't want to. Transition it's not a punishment when you grow up and have to go on to adult care. It should be a good thing.
It seems that there are some standard rules about behavior that's just not acceptable. Then you could not have the race thing be as much as an issue, because it's rules for everybody, but then there's downsides to having broad rules too. So I don't know.
You can take a couple questions online. Those of you online, type them in that chat box and we'll read them out here. Then we'll get back to the studio audience.
The questions are rolling in and they're good. Here's the first one. At what age would you recommend adolescents and young adults be asked how they want to transition to adult hospital settings? And also, how can the actual and perceived differences in care from peds to adult hospitals and clinics be minimized? Do you have a recommended age and the idealized timeline?
So I believe there actually is a recommended age of 14 to 16, depending on the adolescent, and depending a little bit on for starting the process, for starting the conversation, and setting some goals so you by age. And it really depends on the child, but pick an age by which you will be doing your medications at home by yourself, with minimal supervision from your parents. Maybe by 17, calling and scheduling their own appointments so that all of these tasks have been accomplished in the pediatric setting before the switch to the adult setting is made. And then there's recommendations for having some hospitals do joint clinics at the time of transition where the pediatric and adult provider will see the patient together for at least a visit or two, ensuring really good communication and coordination of care. So that's a really nice option. Some of the larger hospitals have adolescent and young adult programs, so you can stretch out the time of transition if you have a clinic that, say, sees patients from 15 to 25 or 26. That's not going to be, I'm in a much geographically smaller area, so that's never going to be an option for us. But just to sort of minimize the differences, to have that really good communication so that you've built up the patient's trust with their new provider before the moment of transition. I think one of the problems we run into is this issue of addiction, and that on the adult side, perceptions of addiction and concerns about addiction are very different than the concerns on the pediatric side. So when you come to the pediatric ED, our goal was to get narcotics administered within 60 minutes. When you come to the adult ED, it's not necessarily not their goal, but making sure you're not drug seeking is much higher on their priority list. So it takes much better communication than we currently have not just between, say, a pediatric subspecialist and an adult subspecialist taking over care, but between all these other pieces of the hospital that the patient is going to interact with when they start the transition process.
Go ahead. You have another one?
Yes. Thank you for this educational, inspiring talk. As a physician educator in pediatrics, I often overhear learners or even other faculty and staff commenting or complaining about the difficult patients. How do you teach learners, students, and residents about the dangers of labeling and while also protecting their training and professional space?
Good question. So I primarily teach undergraduate medical students. I teach ethics and public health in the first year, and I teach clinical ethics in the third year. So that is where I have most control over how this is taught, and certainly will reflect in my answer. So for the first year students, we do case-based education and ethics, and from the beginning, all of their cases are built to have self-reflection questions where we ask them how they feel about this particular patient. So I think there is value in learning to, and I think a lot of psychiatrists would agree, learning to recognize your own feelings towards the patient and recognize them for what they are, and then being able to put them aside as much as possible. Putting them aside is a later trainee skill, but I start with the medical students on just recognizing, how did this patient make you feel and why do you think that was? Sometimes we ask them to, what did you assume about a patient in a vignette? Did you assume things about race or culture? Or what are personal experiences that you've had that you might be bringing to this encounter? So I think that is a really good place to start, well before they are actually the resident getting called in the middle of the night to deal with an angry parent or an angry teenager, that they're thinking about, well, how am I going to react to this and how am I going to put that aside and be calm?
Well,
yes, yes, thank you very much for presentation. Actually, I have two questions. One question and one comment. Right? I think what my colleague Nisha said about dissertation, children care, mental health care centers, with other factors, mental and the issues related to achieve these skills. I think that is more like an emotional attachment, being a doctor, being a physician, rather than anything else. So being a human, I think we develop the emotional attachment that. And then what you said regarding the teaching of bioethics in undergrad, so I think that would be a good initiative initiative that to teach them how to limit their feelings or how to make their. So this is one. And secondly, my second question or comment is that I think this transition is a process rather than a number. I mean, one day you turn 18 and you have turned from minor to adult, but I think that it's a process, as you said, that 16 years, 17 years. Thank you very much.
Thank you. Yes, I think that the issue in putting a number on it is we also think about prognosis and treatment and availability of adult providers. Are we going to transition an 18-year-old who's not likely to make it to 20? Probably not. But an 18-year-old who has a chronic disease that they're likely to have for the next 50 or 60 years, then that's a time when we should be well into the process. So that makes it particularly hard to put a number on it. It also means that on a pediatric hematology oncology unit, you often have young adults in their 20s who have cancers that are primarily found in pediatrics, and they're probably best served by a pediatric oncologist. But it gets very blurry, and especially when you throw in other medical problems that maybe are not well managed by pediatricians.
And sometimes we consult adult providers for problems that we need help with. They could also consult the pediatric oncologist.
Yes, they could. And I had a recent case where the adults quit. The adult consultant chose to quit over non-adherence, which speaks to some of the cultural differences.
Go ahead.
Thank you for the excellent speech. I'm from India, Shanghamitra. I'm just giving one comment. In India, pediatric age group is 12 to 13 years. So pediatrician are treating up to 12 to 13 years. And you can imagine the one after 12 plus, means 13 years boy, he is going to adult world and who is not used to sleep without his mother or father, means without his parent. That is one problem we are facing. And you are very right. It's a transition. There should be a transition from from pediatrician physician to the adult physician. There should be. But here we are facing the problem in India. That is in government sector.
13, wow.
All right, some more online questions. One person notes, families have different dynamics. Some families encourage pediatric patients to not only be a part of the decision-making process, but to be the primary decision maker and to do so before they have the capacity to do that well. What do you suggest to support these families?
I would suggest talking to parents about realistic expectations of decision-making relative to their child's age and intellectual and psychosocial maturity, so that the expectations are realistic. Most 11-year-olds are not going to be able to choose whether they get this treatment or that treatment. At least not in a way that we would consider meaningful, but that doesn't mean they shouldn't be part of a discussion in terms of how the different choices might affect their life and what's important to them. But I think, yeah, there's a big role for pediatricians in helping parents in any situation understand normal child development.
And I think having a structured transition process helps parents with that too, because you take it step by step and you have to succeed at one before you get to the next.
The next one is, I think, approaching you in a sense as for an ethics consultation here. They have a patient story they want to share and get your thoughts on. I have a patient who has autism and epilepsy, who is also nonverbal, very big and muscular and aggressive. He is about to turn 20, and I've had difficulty transitioning him to an adult provider who would be comfortable treating an aggressive autistic patient. The problem is not with the parent wanting to transition, it is with finding an adult doctor who's willing to follow him. I feel like it would be easier and better for the patient if I just continue to follow him as a result of the situation. What are your thoughts?
Yeah, I think that happens a lot, that for the primary provider, it's easier to stay with the patient, and there's very little downside to not staying with your patient if you're the primary provider and they're able to continue seeing you. The downside comes with all of those other aspects of the healthcare system that may not feel comfortable with a patient who's getting older and larger, and is your children's hospital or your pediatric clinic equipped to provide care for a patient of that size? Are the nurses going to be able to help assist him in ways that he needs assistance? So in that sense, it's a really tough situation if you don't have somebody who's willing to take over. But I think sometimes pediatric subspecialists have successfully partnered with the other aspects of the adult hospital. So we will see patients who are admitted to the adult floor as a pediatric consultant, if that's appropriate, like you were sort of suggesting. But it sounds like this patient will eventually need an adult provider. Especially if he's going to be admitted to the hospital for anything, because he's very quickly going to be an adult with adult medical problems that pediatricians are not qualified to treat.
And just to follow up for that person, if you're still listening, is it an inpatient situation or an outpatient situation? And does that make a difference? Angie.
In working with several of our departments here on working on educational pieces for transitioning, one of the things we find is the expectation of a pediatric institution and an expectation of an adult institution, whether it be inpatient or outpatient, is not always congruent. How do we? Because we work with the families step by step by step by step in the pediatric world, but when the patient goes to the adult world, they're all on their own, regardless if it's their family helping them or not. And oftentimes, just like you talked about, the settings and things like that. So it's a very hard transition. How do we work with, I think, getting the doctors together, but it also is maybe some transition spaces we find, in an adult setting or something. Do you have ideas on that?
Yeah, I think transition spaces are great. I mean, when you have the resources and the size to have AYA units and programs, or spaces where older teenagers can interact with young adults in their late 20s who have the same diseases and give each other advice. And some of it's sort of like social marketing, really. How do we sell transition as this is good? This is you growing up and living the rest of your life, even though you have these medical problems or this disease. And it's a positive thing when you're able to take ownership of that, when you're ready to go see an adult provider. I don't know that we necessarily do a good enough job, or maybe it's too obvious that they're losing some of the privileges of being in the pediatric space. But I think we can definitely do more to create those transition spaces.
I think it's so real that pediatrics is just better. I mean, if I was in the hospital, I'd want a child life worker, to come play with me. They don't have them in adult hospitals. We'll get to you in a minute, but one more online.
Well, your request for more information has been received. It's an outpatient situation, and been trying to transition for over a year.
That seems different to me. I mean, to the extent that this is focused on the scarce resource of a children's hospital bed.
There is a great question here, a little bit more philosophical for you. So if we accept, as you suggest, that access to pediatric hospitals is a privilege, then is there any reciprocal obligation upon the adolescent patients in order to avail themselves? Does this privilege have any expectations or responsibilities?
So I think I would argue that it comes with expectations, but not with punishment for not fulfilling those expectations. And really that when adolescents don't meet their responsibilities and expectations, that's not usually a sign of maturity. That's generally indicative of needing more support rather than less support, so that pulling away the support that comes with pediatric care is not going to produce the outcomes that we desire. Doesn't mean that we shouldn't hold them accountable, or there shouldn't be other consequences, which are sometimes difficult to decide, but that the consequence shouldn't be now you have to go to the adult providers, which I also think, and maybe I haven't emphasized this enough, pushes the burden on another set of providers to put up with what is still difficult behavior that made the nurse's days stressful, made people not want to come in and take care of his patient. That the way to solve it is not by pulling away the pediatric support.
Go ahead. You got a microphone. Make sure it has a green line.
One of the things that we've done because we don't have a transition space is to suggest that it's not a one of the things that we do, because we don't have the space, is suggest in the process that they make an appointment with an adult provider before they're totally transitioned. So they can come back and we can kind of talk about how it went and kind of talk about you have to find the right fit type thing. And that's been kind of helpful.
Yeah, that's a great option.
We had someone from Sick Kids in Toronto down here talking about transition in Canada, where the health system says on your 18th birthday, we no longer pay for care in a children's hospital. And one of the things that does, it's an arbitrary rule, but it forces the hospitals to prepare for transition because they know if they don't and the kid's still there, they're not going to get paid. So in some ways, changing the system may require a rule about forced.
Yeah,
transfer.
which would also address some of the questions of inequities and are we transitioning people we just don't want to care for anymore versus those who are really ready.
18.
So I think we're running out of questions online, but I've got a question for you, which is it realistic to think about totally reimagining the way we deliver healthcare? Like in education, we have elementary schools. We don't just send them straight to high schools. We have a middle school period. In some cases, even have a sixth grade center or something like that where kids go. And I'm wondering if the whole way we deliver this, where we bifurcate between a children's hospital and everyone else, if that's the best way of organizing a medical system. And even if it's not, of course, we have to live with the realities we have. And so maybe the best we can do is to create these transition spaces or whatever within the existing institutions. But I'm just curious about your thoughts. Is there, a case to be made for having middle school type facilities where maybe kids, once they get to 10, 11, 12, and I also ask it because our social realities are changing. I mean, kids are living with their parents much longer. They may not get jobs as early as they once did. They're not getting married as early. So maybe the best thing is to have a 1 through 12 and then a 13 through 24 and then everyone else. I don't know.
No, I mean, I think there really is. And some of my most valuable colleagues are med peds who are doing adolescent because there's especially as we see more obesity, we see more chronic diseases in teenagers that were not a part of standard pediatric training. So having more of a bridge where there's communication between pediatric and adult providers or where they're working together to take care of the same patient group would be really helpful in some ways. I think sometimes it's a really artificial dichotomy, like our pediatric surgeons won't put ports in 18-year-olds, and we think, well, why not? And then you pull in this other service that we don't usually work with, but if we had more of an adolescent zone and agreement on these providers are really interested in taking care of adolescents and really familiar with the issues that go along with it, that would be a much better way to go about it. It goes for a lot of our support services too, some of our psychosocial care, where people really do have inclinations and styles and preferences, and they like working with younger children or with older children. But where we have, now you're 18, you need to see this psychologist and you can't see that psychologist, it sets us up to have difficulties and to have difficulties like this situation.
It seems like in general we have very mixed signals to when you're supposed to be able to do things in this world, right? And so you can drive at 16, you can vote at 18, but you can't drink a beer until you're 21. And we want, and this seems like one of the things that's 18 seems to be the implicit suggestion you should be moving on at that point. And I just wonder if the whole thing has to be rethought.
13 in India then.
13 in India, yes.
Right, Mary.
We've been discussing that it's a whole process. Transition is a process. So like a child who has been in hematological scenario and has been seeing a pediatric oncologist and has been shifting to, is going through that transition phase and been shifting to the adult oncology, hem-oncology service. And patient still is very much comfortable with the pediatric oncologist. And for sure, the service has been changed, but the child or the person himself wants to see the pediatric oncologist. And how do you suggest to bridge the gap between the pediatric oncologist and the adult oncologist to overcome that transition process for the patient?
Yeah, so most, and this is maybe where it gets even more gray, and most of the time on the oncology side, we won't transition someone who's in active therapy. So we keep them with pediatrics until they're done one way or the other. So the transition usually happens in the survivor zone when they're off therapy, when we think they're cured, and sometimes quite a bit later. So how do you get people? showing trust on our part and our adult counterparts is part of that. And I think sometimes we inadvertently sort of send those mixed messages of, oh, you know what, I'm sure patients hear people say negative things about the adult side of things. It's not as pretty, it's not as nice, it's not as bright. But even about the adult providers, they don't have as much time. I have 40-minute slots for my patients. The adult oncologists definitely do not have 40-minute appointment slots. So sort of going back to what I was saying earlier, if we show trust in the adult providers and help build that relationship, and then show the patients that this is a good milestone to reach. Yes, there are things you lose by not being a child anymore, but there are so many good things about being an adult. And I don't think we have necessarily done a great job of conveying that to our patients and setting them up for that. But some of that goes to us respecting our colleagues on the other side.
We've reached the end of our hour and the end of our year for webinars. So thank you, everybody online who joined us. We'll be back in the fall. We'll send the schedule around as soon as we get it. Thanks again to Children's Mercy Hospital and the Claire Giannini Trust for supporting these webinars. And let's thank Amy again.